having some renal rot.
Good morning, all. I'm presenting behalf of Medicine 3. My topic is renal rot. Mrs. D, a 65-year-old female from Gudiyatham, presented with the complaints of not passing urine for 2 days. History of presenting illness, she was apparently well 1 month back. Then she developed left flank pain, which was gradual in onset, non-progressive, and no aggravating factor, and relieved by medication. She's taking outside injection. And there is a history of associated with the vomiting. And there is a worsening of the pain for last 1 week, followed by not passing urine for 2 days. And there was no history of blood stain while passing urine and previously, and no dysuria, no fever, and history of loss of appetite was present. Past history-wise, patient is a known case of diabetic mellitus for 10 years. The index presentation was polyuria and paresthesia, and there is a history of blurring of vision was present. There is no hypoglycemic and decay episode in the past, and known hypertension for 10 years. And there is no history of cardiovascular disease and cerebrovascular accident and bronchial asthma and TB in the past. And personal history, patient consumed mixed diet and history of taking over-the-counter medication for last 6 months, and there is a history of using snuffing frequently. So no CAM intake. And treatment history, patients on amlodipine 5 mg OD and metformin 500 mg BD. So outside report, in the initial presentation, the hemoglobin was 12.3 and creatinine was 2.1 and HbA1c was 5.8. And ultrasound abdomen shows there is a left urinary calculus with a mild left hydrouridonephrosis. So during presentation, the vital signs, pulse rate was 86 per minute, BP was 160 by 100, and respiratory was 22, temperature was 98, and saturation was 98 minutes. And on examination, pallor was present, and pedal edema, bilateral pitting up to below knee, and there is no icterus lymphadenopathy clubbing, and there is a hypopigmented patch in the bilateral foot. There is a acral vitiligo since birth now, and there is a cataract in the both thigh was noted. Systemic examination, CVS first and second heart sound had no murmur, respiratory system, bilateral normal vesicular breath sound had no added sound, per abdomen also is soft, non-tender, and no hepatosplenomegaly, no renal angle tenderness was noted. And CNS also no focal neurological deficit. So with this, the differential was considered was renal calculi, acute pyelonephritis with the background of the diabetic mellitus, and there is a history of vomiting was present. There is a dehydration and leads to papillary necrosis. And initial investigation shows the WBC of 17,700 with a neutrophil of 83%, and lymphocyte was 6%, and monocyte was 10%. And hemoglobin was 11.4, and platelet was 3.9 lakh, and urea was 51, and creatinine was 4.4, and sodium was 113, and potassium was 5.1, and bicarb was 10. And LFT was normal, and HbA1c was 11.8, and 8M cortisol was done, and it shows 19.2, and blood culture was done, it was negative, and BB was also negative. And we done a CT KUB. It shows that there is a bulky bilateral kidney with the perinephric fat staining and a mild left hydronephrosis, which is suggestive of bilateral pyelonephritis. So for the hydronephrosis, he underwent the PCN drainage. It shows there is a pus. We sent a culture and it grew aspergillus flavus. And we done a galactomannan assay as also positive for this patient. So I'm going to briefly talking about the fungal pyelonephritis. So the aspergillus is the primary pulmonary pathogen. The isolated renal infection was seen in 13% of the cases. Mostly is arising from the hematogenous spread or continuous spread from the adjacent organ. And the study shows that there is a murine aspergillosis. They inject the aspergillus fungus through the IV, and they documented as the kidney carrying the highest burden of the in this study. They show that the aspergillus flavus we injected to the IV is reside in the kidney. 50% of the aspergillus was in the kidney, and there is a risk factor for the fungal pyelonephritis, genitourinary instrumentation and seropositive and malignancy and transmittal and immunosuppression. So this study was shows that there is a isolated renal and urinary tract aspergillosis. Which systemic review they were done. The total 91 cases, the 50 cases was species identification was done, and 41 cases was histopathological evidence. And the species was Aspergillus fumigatus was 39 cases, and Aspergillus flavus was 9 cases, and Aspergillus niger was 1 cases. And Galactomana assay was done in only 4 cases that was positive. And the geographical distribution was fungal Aspergillus pyelonephritis is more common in India. So total 50 cases among the 91 cases, 50 cases was reported in India. So treatment, we have amphotericin B and azoles and nephrectomy. If the patient have the renal involvement, will go for the nephrectomy. And in this study, they done a combination therapy. It shows that patient was started on amphotericin B. They have a survival rate of 50%. And so for the azole and other antifungal was have a survival rate of more than 70%. So come to our patients. Our patient was started with the oriconazole 200 mg for 2 weeks, and patient was in the ward. The patient had a refractory metabolic acidosis. For that patient underwent the dialysis. 3 settings was done, and after the second day of dialysis, patient was passed to urine. So during discharge, the urine output was 1600, and patient was planned for retrograde pyelogram and ureteroscopy. So the landing point is the patient was presented with the left. In the outside report shows that there is a left ureteric calculus. It is not a calculus; it's mostly fungal ball. So we cannot find the organism, and CT also shows that there is nothing. There is no obstruction in the CT also is not there. So therefore we are planning for the retrograde pyelogram and retrograde pyelogram and ureteroscopy. So the treatment was 200 mg for 2 weeks for the isolated. So the patient had the galactomana was positive. We searched other X-ray was done, and we shows there is X-ray was normal. If the galactomana was positive, there is a chance of getting invasive aspergillosis. So patient is under follow in the OPD basis. Thank you.
Any questions?
Urine routine. Patient was not positive urine for the from day of admission. After passing, we send the catheter sample, ma'am. It shows the WBC of 300 and RBC of 200, and otherwise everything was normal.
You got a PCN sample, no?
Or PCN pus was
Yeah, that's what. So that would have been them. Okay.
No, ma'am. 1 month, ma'am. 2 months of. Yes, anuria was 2 days only. Patient was 1 month. 1 month history of chronic.
The sugar at admission was what?
HbA1c was 11.8, ma'am. It's uncontrolled.
Your LFT is not normal. Your albumin is 2.
Yes. No, sir. We after the admission, we are screening the patient. It's a moderate hydronephrosis. That's why we put a PC.
So it grew in front of your eyes, huh? It grew in front of your eyes. Is the patient okay now?
Yes, ma'am. Patient is under follow-up. OPD follow-up.
OPD.
Yes, ma'am.
Sugars are under control.
Yes, ma'am. We discussed with the ID, sir. They also wanted to shut our reconstruction. The study was most probably from the Indian data. It shows that there is a patient started with the amphotericin B, shows the less survival rate. So 50% of survival rate, sir. So we started on.
Post scan, no? After that,
Huh?
what is kidney size and all post?
And bulky, no, ma'am, but
No, after the after in your follow-up,
the follow-up,
just check that out. The kidney functioning. What is the kidney function at the post discharge?
urine output was improving.
No, no,
And the
kidney function. Create.
create was 5, ma'am, at the time of the discharge.
No,
Initially,
now you're in follow-up, no? So
Yes,
what is
ma'am.
the create?
last was 5.8. Patient is presentation 4.4, ma'am.
Yeah, but before that, this baseline was 2 something, no?
Yes, ma'am, 2, ma'am, and patient presentation 4.4, and after the follow, the ward also there is a 7, ma'am. 7.
So it's 5
After-
points.
Yes, ma'am. After that is decreasing trend, ma'am.
Okay. Thanks.
Thank you.